Good evening, friends. Welcome to Tuesday Critical Care and Emergency Updates and the interactive sessions. We bring you some interesting and probably burning hot topics to have an interaction with our experts. So today we have another burning issue or a debate issue where we are using a lot of monoclonal cocktail antibodies across the globe in a different category of patients. And to probably take you through that journey, we have two components of today's discussion. We have Dr. Abhishek, who is our consultant in critical care department. He will take us through a brief the review of literature over the next 15 minutes or so, and followed by we have our expert, Dr. Nagarjuna Mathur, who has been a senior interventional pulmonologist in Somajigoda Yashoda Group of Hospitals. He has been on the lead of interventional pulmonology and in the COVID pandemic, taking the whole load of the Somajigoda branch. So we invite both of you. Now I request Dr. Abhishek to start his presentation. Over to you, Dr. Abhishek.
Thank you, Venkat sir. Thank you, Nagarjuna sir, for being the analyst for this session. Good evening, everyone. Today we are going to talk about monoclonal antibody cocktail therapy in the COVID. So this is I'm going to talk about all the review of literature and what next. So first, just a second.
Hi, Dr. Abhishek. Can you hear me?
Yeah, sorry. Yeah. Okay, so sorry for that. So we'll start the talk. So we'll talk about what are monoclonal antibodies. Monoclonal antibodies, these are agents that are produced from the specific pathogen B cells for the patients who have recently recovered from the infection, or by immunizing the mice that have been genetically modified to have immunized immune system and harvesting the effective antibodies from them. So once these B cells are identified, the genes of this immunoglobulins are recovered and they are expressed to produce these monoclonal antibodies. So these monoclonal antibodies are under the investigation for COVID-19 treatment. So how do they act? So if you see here, the monoclonal antibodies have a singular activity. They go and adhere to the predetermined target. So they therefore differ from the convalescent plasma, which consists of polyclonal antibodies. So here they go and attach to the predetermined target. Previously, monoclonal antibodies have been effective against respiratory syncytial virus and Ebola virus, and they have been FDA approved. So here again, how do they act? See, as we all know, the SARS-2 infection, actually the virus goes and attaches to the ACE2 inhibitors on the surface of the host cells. So what these monoclonal antibodies do is they target the spike protein and attach to the virus, so the virus won't be able to enter the host cells. So in this way, they block the entry of the virus into the human cells. So actually, there are two companies that have been producing monoclonal antibodies. That is Eli Lilly's bamlanivimab and etesevimab is one, and Regeneron's casirivimab and imdevimab. So this bamlanivimab, this combination is called as LICE-CoV, whereas casirivimab and imdevimab combination is called as REGEN-CoV. So in my further talk, I'm going to address them as LICE-CoV and REGEN-CoV. So why they use a combination of antibodies is, as we know, there have been viruses that have been escaping the immunity and they've been developing resistance. So to counter this, to reduce the possibility of lack of effectiveness, they are combining the two antibodies so that virus can't escape the therapy. So first, let us look at the review of literature of the antibody cocktail in the management of outpatients. So this was a trial that was published in NEJM. This is about Regencov. This was published in Jan 2021. So the clinical question that this trial asked is that does Regencov reduce the viral load, lead to improvement and reduce the medical attendance in outpatients of COVID-19? So this was a multi-center randomized trial, placebo-controlled trial that was conducted in non-hospitalized patients in COVID-19, as we all know. It was this publication is actually an interim analysis of only 275 patients. Inclusion criteria: all the adults who were more than 18 years who were positive within 70 hours of randomization, who had symptoms within 7 days of randomization were included. Patients who were excluded were the patients requiring hospital admissions, who have been enrolled in other studies to receive monoclonal antibodies, who have been planned for convalescent plasma. These patients were excluded. So this study, they have randomized the patients into 3 arms. 306 patients were taken. They are randomized into like 100 patients in each arm. So one arm was given 2.4 grams, that is low dose of Regencov. The other arm was given 8 grams, and the third arm was a placebo group. So if you see at baseline, 45% of the patients were at serum antibody seropositive at admission. I mean, when they were randomized, and 41% were antibody negative, and 14% had unknown antibody status. So if you see here, obviously the patients who were seronegative had very higher viral loads compared to the patient who were seropositive. Other baseline characteristics were adequately matched, and how Regencov was given is irrespective of high dose or low dose. It was mixed with 250 ml of normal saline and given over a period of 1 hour. So here you can see the primary endpoint was the decrease in the viral load through day 7. So it was significantly reduced both in a 2.4 gram group as well as low dose and high dose group. There was significant reduction in the virus load. This effect was more profound in the patients who were seronegative at admissions. That means who didn't mount the antibody response to the infection. They had a better control of the viral load compared to the antibody positive patients. Okay, and now when we look at the secondary outcome, that is the number of medical visits. Here, medical visits were patients who contacted the doctor through tele-ICU, who went to telemedicine, ER, or a type OP visits. So all these patients were taken. So this was not significant. Here you can see only 3%. It was only 3 percentage point difference in the medical visits. Even the seronegative group also, the difference was not much significant. So here, this is an interesting slide. You can see the higher the viral load during the randomization, more rapid was the clearance. So the patients who had a high viral load at randomization had quicker clearance. That means the seronegative patients. So here, the final conclusions of the study were like Regencov enhanced the clearance of virus, particularly in whom the endogenous immune response has not yet been initiated. That means the seronegative patients who had high viral load at the baseline. But clinical efficacy, that is medical attended visits, were not statistically significant. So here they again compared the any adverse effects between the Regencov group and the placebo group. There were no serious adverse effect, and even if the adverse effects were there, they're almost equal in both the treatment group as well as the placebo group. So Regencov was declared safe in this trial. So coming to the limitations of the trial, as I said, it's an interim analysis and it's a very small sample size. And the Regeneron, the company that supplies the drug, had involvement in this trial. So certain employees of Regeneron had access to the unblinded data from the trial. So that might have created some kind of bias. Viral load, which is a primary outcome, is not a patient-centered outcome. And here telehealth was considered as a medically attended visit. So there may be some patients who may be anxious, who try to call the doctor. So I think that might have created some bias. So So therefore, to address these problems, the small sample size and all the other problems, the Roche group, the Roche company itself, they have conducted 2 trials. That is REGEN-COVID 2067 and REGEN-COVID 20145. REGEN-COVID 2067 was conducted in high-risk non-hospitalized patients with COVID-19, and REGEN-COVID 20145 was conducted in low-risk asymptomatic or symptomatic patients with COVID-19, outpatients. This is also an outpatient trial. So this is a phase 3 randomized placebo-controlled double-blind study. Here the inclusion criteria are the same, like what I mentioned before, who have been non-hospitalized, less than 7 days of symptoms and less than 3 days since being tested positive. Here you look at the sample size. Sample size is quite large. 4,506 patients were randomized. Here you can see, here they have actually divided into 4 arms. One arm of the treatment group was given 1200 mg and other arm was given 2400 mg. So they have compared these arms with the placebo group. There was 70% risk reduction in the COVID-related hospitalizations or death by day 29. It is equal between both the doses. You see, it is 70% in the 1200 mg group and 2400 and 70% in the 2400 mg group. And if you look at the time to COVID-19 symptom resolution, it was 4 days quicker in the treatment group compared to the placebo group. Here also there was no difference between the doses. So whether it is 1.2 gram dose or 2.4 gram dose, the outcome was similar. So again, this was the first trial. This was the second trial, which was 20145. This was conducted in low-risk patients, right, whom I told. So here what they looked at is, they looked at the clearance of the viral load. Here in this trial, they involved 803 patients. But in this trial, what they have done is they have given all the doses ranging from 300 mg to 2400 mg, and they were given in different routes. They were given in intravenous as well as subcutaneous doses. So here, this trial showed that throughout all the range of doses, there was significant and comparable viral load reduction after giving the drug. So whether it is 300 mg or 2400 mg, there was, and irrespective of the route also, there was a comparable viral load reduction. So coming to the limitations of this trial is actually this data is actually media release. It's still being reviewed. And the risk of bias is there because it's again a company-backed trial. Detailed data is yet to be published. So we are actually waiting for that. So these trials have concluded that not only there's a clearance in the better clearance of the viral load, but also there is a clinical benefit. But the data is yet to be totally published in any journal. So this was about REGEN-COVID in the OP patients. Now let us look at Bamlanivimab, that is LICE-COVID in the outpatient management. This is a BLAZE-1 trial. BLAZE-1 trial, it's a multi-part trial actually. So first the phase 2 and early part of phase 3 trial was published in JAMA, and the original part of phase 3 trial was published in NEJM. So first we'll look at the the early phase 3 part. It's as we all know, it's a randomized double-blind placebo-controlled trial. Here again, the population inclusion is the same. So I won't repeat it again. Then look at the exclusion criteria. These are almost the patients who require hospitalization, saturation less than 93 on room air, tachypneic, tachycardic patients, or who were considered for the convalescent plasma therapy. So these patients were excluded. So here, look at first when they started the trial, they started only with the Bamlanivimab. They didn't combine it with Etesevimab. But when the trial was ongoing, they have noticed that the virus was able to escape this Bamlanivimab therapy. So they have added Etesevimab so that it provides it can cross the antibody resistance. Viral resistance. So 2800 mg Bamlanivimab plus 2800 mg Etesevimab was added. That is LICE-COVID, and the last arm which was given placebo therapy. So all the arms had almost equal number of patients. So here you can see that only the combination group had a change in the viral load compared to the placebo therapy and decrease in the hospitalizations. Whether if it is a single Bamlanivimab, it was almost same. There was no much difference between the placebo group and the treatment group. So you can see the graph, the blue line that indicates the combination therapy, you can see a significant decrease in the viral load here. So statistically significant difference in the change in the viral load as well as number of hospitalizations was seen only in the combination therapy when both bamlanivimab and etesevimab are combined. So the conclusion was among the non-hospitalized patients, treatment with LICE-CoV was associated with significant decrease in the viral load, but they have concluded that still the trial is ongoing to show the clinical benefit. So this later part of the trial, that is phase 3 part of the trial, tried to see if there's any clinical benefit. Here there was small change in the study population. Here they have included the adolescent patients also. So adolescent patients and the patients who were at high risk for progressing to severe COVID were included. So 1,035 patients were included here. This was conducted from September 2020 to December 2020. So here you can see the high risk factors for severe COVID are age more than 65 years, BMI more than 35, and certain medical conditions like CKD, diabetes mellitus, immunocompromised patients. So all these patients were included. You can see that there was the baseline characteristics were properly matched. There was no much difference in the baseline characteristics. 1,035 patients were randomized here. So the primary outcome, if you see the number of hospitalizations or death was only 2.1% in the LICE-CoV group compared to 7% in the placebo group. So the difference is almost 4.8 percentage points, and the p-value is less than 0.001. That is quite significant. So definitely there was a decrease in the hospitalization rate with the combination therapy. Coming to secondary outcomes, you can see there was 16 times higher reduction in the viral load over to day 7 in the treatment group compared to the placebo group. Even the median time to resolution of symptoms was 1 day shorter in the cocktail group. So what this trial has concluded is the viral load can be a potential biomarker that may correlate with the clinical outcome. So as the viral load comes down, maybe the clinical improvement of the patient can also be seen. So that's what this trial has concluded. Here also, in this trial also, the adverse effects were almost similar. It is 1.4% in the combination group as well, treatment group, whereas it was 1% in the placebo group. So this indicates that again, this LICE-CoV also has an acceptable safety profile for use in high risk population. So as I said, the conclusion is not only it has shown the decrease in the viral load, but also it has shown the clinical benefit. So based on this evidence, FDA has granted emergency authorization for the combination, both LICE-CoV and resumption in the treatment of mild to moderate COVID-19 non-hospitalized patients who are at a high risk of progressing to severe disease. Even the Central Drug Control of India for the resumption. Now, CIPLA has partnered with Regeneron and is all about the inpatient hospitalized patients. This study comes from the very famous recovery group. So this recovery group, as we all know, this trial has already shown the decreased mortality with dexamethasone and tocilizumab patient in hypoxic COVID patient. Again, if this cocktail is going to be effective in the hospitalized COVID patients. This is again a randomized trial that was conducted from September 2020 to May 2021. They did for a pretty long time, and all the patients clinically suspected infection. Here you see even the pregnant and breastfeeding women also included. Coming here, the patients who are less than 40 and age less than 12 years received the globulin therapy before excluded. A large sample, 6,785 randomly allocated to receive either the placebo. 32% were seronegative on admission, 54% were seropositive, and 14% had unknown status. And see the amount of DM was large. Here they gave 8 grams, 8 grams, that is 4 grams of each. As soon as possible after baseline characters, there were equally matched throughout the study. Whether it was positive, the baseline characters were equally matched. So similar in all these patients. And they have matched this also. The COVID patients will be other drugs, so some may think the other drugs might have caused the change. There was even when it comes to, so all the drugs which have shown benefit like equal, they're properly matched. Into the results, so you can look at the graph. The primary outcome, which was mortality, was 24% in the seronegative patients and 30% in the placebo group. So this difference was mortality benefit was seen only in the seronegative patients. It was almost 6% difference, with the p-value being less than 0.05. Whereas when they compared all the participants with the whether it is combining both sero positive and sero negative, there were no much differences. So only the sero negative patients had the benefit. And if we look at the other outcomes, apart from the mortality, even the patient who were discharged alive from the hospital was more in seronegative patients, but it was not statistically significant when they took the whole group into consideration. And again, the patients who are not on invasive mechanical ventilation, the patients who were on oxygen therapy, who were on NIV, the number of patients who landed up on mechanical ventilation was also low in the seronegative group. So when we look at the other outcomes like progression to renal replacement, non-COVID mortality, that was equal in all the patients, even if even the seronegative patients had similar outcomes like the placebo group. So only the mortality in the COVID seronegative patients were better. So here it was a large population safety profile. Again, you can see in the slide, if you look at the adverse effects, it was almost equal in the treatment group as well as the placebo group. So what this trial has concluded is even at a higher doses, antibody cocktail is definitely safe. So that's what this trial has commented on the safety profile. So coming to the strengths of the trial, it was a randomized large sample size trial, and 99% of the patients were followed up for the primary outcome. And the other plus point is this comes from the very famous recovery group that has proven benefits for many other therapies. And Regeneron here has just supplied the drug. They didn't have any role in the data analysis, in the study design, or in submitting of publications. So it was entirely done by the investigators. So the conclusion is, what they concluded is, in summary, this large randomized trial provides the first evidence that Regencov can reduce the mortality in the hospitalized patients, and only in the seronegative patients on admission. So here I'll just show you the cost of the drug. So if we are planning to manage a patient in the outpatient, it's going to cost about 200 mg is going to cost about nearly 60,000. So a multi-dose pack generally can be used to treat 2 patients. So if you want to treat 1 patient on OP basis, generally it's going to cost 60,000. Whereas in hospitalized patients where 8 grams is used, it will cost around 3.6 to 3.8 lakhs. This is according to the recovery, because they have recommended to use 4 grams of each antibody, monoclonal antibody. So that's the combined cost is going to cost about 3.6 to 4 lakhs per patient. So so previously we discussed about the patient, outpatient and the inpatients. Now, what about the patients who are not infected yet, but they are exposed to a infected person? So even this was looked upon, and this was published in very recently on August 4, 2021. Here also the sample size was quite large. 1,500 patients were taken. Here what they have done is they have given 1,200 mg of drug to the patients who were exposed to they were not infected yet, they were just exposed to the infected patients. So here the trial has clearly shown that the number of patients who it has prevented the symptomatic COVID-19 infections when they are given prophylactically. So out of 750, I mean, only 1.5% of the patients in Regen-COVID group had infection, whereas it was 8% in the placebo group. So this is definitely statistically significant. So that was it. And so the take-home point, what I would like to say is monoclonal antibody cocktail therapy has shown to prevent hospitalizations in COVID-19 infected outpatients who were at the high risk for severe disease, definitely reduce the mortality in only in seronegative hospitalized patients, 1.2 gram or 2.4 gram Regen-COVID dose per outpatients, whereas it is 8 grams Regen-COVID for the hospitalized patients. Monoclonal antibody cocktails have a good safety profile that was proven throughout all the studies, and further trials are ongoing, and we should come up with more trials to give more robust evidence. There are other anti-cytokine antibodies, lemzilumab, these are still under trial, so you have to wait for these results also. Thank you.
Good, sir. Please unmute yourself.
Thank you, Abhishek, for your eloquent, quick presentation. I think you touched upon all the recent literature. So with this, we will take you to the discussion with Dr. Nagarjan Mathur. Sir, I think that for the last 4-5 months after the peak of the second wave, we got this cocktail of monoclonal antibody approved, and thanks to the industry Cipla, which actually could bring this to India and was available with us. From that time, we have been seeing these studies coming after January till August latest, which was in the last month. So many of our clinicians who have been practicing in and around, not just in the cities, but in the peripheries, had a lot of queries in their mind. Just to actually recapitulate what Dr. Abhishek already pointed out, what exactly are these monoclonal antibodies? See, we have been thinking about a convalescent plasma for last 2 years or so, close to 1.5 years or 2 years or so. So we were talking about antibodies, and then initially we said it should be given in early phase. Then we said, look at the antibodies. If they're negative, give the plasma in early phase, it may prevent. Then we said, no, plasma is not helping nowadays. So there is no evidence in suggesting this. And now we are talking about again another antibodies, which we are saying monoclonal antibodies, and we are talking about cocktail. So what exactly are they? And how are they different from the regular convalescent plasma, which we used to last for 1.5 years or so? Dr. Mathur.
Thank you so much, Dr. Venkat. So before I give my answer, I think first I should appreciate or thank you for choosing this topic. This is actually very, very important because I feel that this has actually completely changed the way we approached COVID-19. So it is something like pre-antibody cocktail, what we used to give, and now the whole approach has changed. And as the title of the webinar says, magic bullet, yes, definitely, probably, yes, I'll be answering why also. And it has completely changed our way we treat COVID-19 nowadays. So, and I would also like to thank Dr. Abhishek for the excellent review. I think he has beautifully summarized the 3 important RCTs. And now we'll be discussing more about our practical experience and the questions which will be put on by Dr. Venkat. So what exactly are these monoclonal antibodies? Basically, see, just like any other disease, these are focused antibodies to anti-spike antibodies, which prevent the virus from attaching to the cell, entering the cell. And as Dr. Abhishek has rightly said, they have a lot of clinical benefit. And how do they differ from the convalescent plasma? Again, this was pointed out by Dr. Abhishek also, that convalescent plasma is not only this antibody, it's basically polyclonal antibodies. And the titers in the convalescent plasma probably are much less than what we would achieve by giving monoclonal antibody. So basically, monoclonal antibody is much high titer than convalescent plasma, and they're much, much more specific. So basically, what you want is anti-spike antibody. That is what we're actually giving. So that is how monoclonal antibodies are different from plasma, and that is why what plasma has not shown the clinical benefit, antibodies are able to show the clinical benefit.
So you mean to say we had a convalescent plasma which probably had a polyclonal, and we don't know the definite effect of it, but it is a more a refined product which is actually attacking or targeting the appropriate receptors or blocking that. Maybe that's the reason why we are. There are some questions on the box which says, suppose one of our patient is got vaccinated in the last April or so as a first dose, and he's waiting for the second dose to happen, and in between this patient gets infected and turns to be a COVID positive symptomatic. What is the role of this monoclonal antibody cocktail in these group of patients?
See, again, this is a very common question which is posed by doctors as well as patients, that I've already taken 2 doses of vaccine. I've taken 1 dose of vaccine. So why should I take the antibody cocktail? But most of the international authorities clearly mention that do not discriminate patients based on the vaccine status. So irrespective of the vaccine status, if the person fulfills the criteria for antibody cocktail, it has to be administered. This is very important because the efficacy of any vaccine is only 70% of what we have in our country. We don't have Pfizer and Moderna, but whatever we have, it is only 70%. So if we presume that the vaccine is working, then 30% of the times you're wrong. And you'll be denying these 30% the benefit of the antibody cocktail. So it is best not to guess. And irrespective of the vaccine status, if the person fulfills the criteria, if the person can afford the antibody cocktail, I would strongly suggest it has to be given.
So Dr. Mathur, I just wanted to know which are the patients in your clinical practice where you choose this monoclonal cocktail antibody. I know we are discussing about different category of patients with got exposed and they are high risk patient who come to you with maybe a mild symptoms or a moderate symptoms not requiring hospitalization, and patients again a category who got hospitalized and sick in ICU. So in whom you actually choose to give this monoclonal antibodies?
Excellent question, sir. In here, I think in our center, the last 3 months, we've given it to more than 200 patients. So the majority of them are people in the early stages of disease with mild COVID infection, mild to moderate. Before the onset of hypoxemia, before the onset of pulmonary infiltrates. So this is the majority of them. This was based upon the trial which he has already shown, that when we give it early in the course of disease, then there is a 80% chance that it will prevent progression. So most of our patients are high risk OPD patients. And normally, though the Indian recommendation says you can give up to 10 days from symptom onset, and the trials have included 7 days from symptom onset, what I feel is the earlier we give, the better it is. Logically also, it prevents virus entry into the cell. So if we can give it early, then it is even better. So in our practice, we give highest priority to those who are coming in the first 5 days. Till 7 days also we usually give. 7 to 10 days, very less often we give. Because what we feel is that in the first 5 days only, this is working very good. And in our last, I think 180, 200 odd patients whom we had given, those people whom we had given in the first 1 to 2 days, I think 100% of them didn't develop any symptom also. So usually it happens when a husband is admitted and a wife develops symptoms. So in the first day itself, you can test, in the first day itself, you can give the antibody cocktail. So what we have seen is the earlier we give, the better it is. Here, there are 2 things which we have to which we also have to tell. When we are talking about administering the cocktail, the second question which many patients have, and in fact, many doctors also have, is the person is fine. Why should we give the antibody cocktail now? Why should we give such an expensive medicine? So this, I think I would like to say very strongly that this medicine is one of the prime indications is to prevent disease progression. So you don't want to wait for the disease to progress and then think of giving antibody cocktail. So it has to be given when the person is early, mild symptomatic or asymptomatic, and preferably in the high risk group. So high risk groups also have been clearly defined. in all the regulatory guidelines, you can see the list of the high risk groups, but also there is a clause in the ending saying that in addition to these listed indications, if the physician feels that he is a high risk person, also you can give. So in India, a lot of people have high risks. Obesity also is one thing which I would like to focus, that people who have no diabetes, no hypertension, but just obese, please treat them. Pregnancy also is now recategorized as a high risk group. So I think there's one more question about pregnancy. So it can be given in pregnancy or lactating mothers also. And now there are two more indications. One is these high risk groups typically were pre-Delta. So when the Delta virus came, what we had observed is many of the otherwise very healthy people also, I think Dr. Venkat and Dr. Abhishek also will agree with me, that we'd see a lot of very young people without comorbidities getting affected.
Yes.
So this question has been in my mind, that if we are giving a high risk group, anyway we are treating, but this new strains Delta virus also seems to be affecting a percentage of people who have no risk factors for disease progression conventionally. So should we not give antibody cocktail in this subgroup? I think this is one question which has not been very clearly answered. We should await the results of the other trial which Dr. Abhishek was talking about, low risk or asymptomatic people, how this will make a difference. But what we are following is, if a person fulfills the criteria in the first 5 days, sometimes even if the person is asymptomatic or in the low risk group, and he asks for the antibody cocktail and he can afford an antibody cocktail, you're not wrong in giving it to this group of people also. So high risk early disease, definitely yes, definitely yes. In low risk early disease, still you can give, there is no harm in giving it, but the benefit of the magnitude of benefit may be lesser in this subset. Now, how the disease, how the evidence is evolving now, in the last 2 months, the data on post-exposure prophylaxis also has come.
Yes.
So now in the last 2 to 4 weeks, we're also giving this as a post-exposure prophylaxis. So
Yes.
if a person is positive and you have elders in the home, then we're also offering the antibody cocktail to the elders. Some are accepting, some are not accepting, but then I think this is a very, very important indication. The only drug in COVID where post-exposure prophylaxis trial has shown a significant reduction is antibody cocktail. I think this is one thing which people have not started using, but people have to use, is as a post-exposure prophylaxis, especially for, in the trial also, they have included high-risk group and people who are partially or unvaccinated. So you're not vaccinated, you're in the high-risk group and you have a close household contact, then please suggest antibody cocktail and you can give. And we have started giving the same thing in the last 2 to 4 weeks. And as the trial has shown, 80% symptomatic infections can be prevented. And even if a person becomes positive after this thing, then it has been shown that the viral loads are lesser and the duration of symptoms is much lesser. So the second important indication is as a post-exposure prophylaxis. This is a new indication and I think we should all start using it for high-risk contacts. Third indication also, I think Dr. Abhishek has spoken, but we have not used it very often, is the sicker inpatients, people who are on oxygen, people who are on NIV or on ventilator, whether this will make a difference. I would agree with the trial that in seronegative, it has made a difference, but practically speaking, a cost, if you have to give, we have to give the correct dose, that is 4 grams plus 4 grams, which is a huge cost. So I think we have not given that dose to anyone because of the cost reasons. Two, logically speaking also, that is the inflammatory phase where the viremia has come down. So how will this make a difference is something which is a logical question, but the data is otherwise. And here I would also like to make one more point, that any drug which is approved and good is also overused. So nowadays what we are seeing is in many centers, in admitted sick patients also, they're giving the cocktail. It is not wrong to give the cocktail, but they give the cocktail at 600 plus 600 mg dosage, that is at 1200 mg dosage. I think this has not been shown to have any clinical benefit. So I think if you want to give it to inpatients, check the zero status. If they're antibody negative, only then we should give. But when we want to give, we should give the full dose. But very frankly speaking, we have not given that dose to any one person yet. I think this is our experience, Dr. Venkat.
Yeah, I think that's an excellent way of expressing. You categorize three ways. One important component which we are now coming across is post-exposure prophylaxis. I just wanted to re-emphasize that, Dr. Nagarjuna, we have been using these monoclonal antibodies in rabies too. See, the monoclonal antibodies has been not new even in the post-exposure prophylaxis. So this has been a component where any patient who gets actually a dog bite with a risk of rabies, they used to get this monoclonal antibody. So the prophylaxis, which if a patient is indicated partially immunized, or as he pointed out, non-immunized, high-risk elderly patient getting exposed, maybe a group we may get benefit, who may get benefit from this monoclonal. That's one category. The other, he said early, that maybe probably as early as possible. He pointed out not just waiting for 7 days, 5 days, 10 days, as early as possible. But as for the trials, it is 7 days. As for the FDA approval, they extended it up to 10 days. And the other criteria they made is the patient is not requiring oxygen. Whereas we just saw steroids in dexamethasone are used more in patients who required oxygen. He said you give this monoclonal cocktail antibodies, those who have not required oxygen yet, but they are in the hospital for an OPD follow-up, and they are at higher risk. Now, as a very interesting concern he raised, we have seen, we completely agree with you, Dr. Nagarjuna, that we also saw some of the younger patients who very rapidly deteriorated in the last pandemic, particularly in the last wave. So that's again a gray area. We have seen a huge population got infected, and among them, the youngest also being a part of it. But whether this cocktail is going to help them or not, we really don't have a data, because again, this was more focused in higher risk groups. So these individuals who are otherwise healthy, but there are many permutation combination, as you pointed out. If a patient is obese, so we need to see a BMI. They consider a BMI more than 25, 30 as overweight, obese, and adding to that hypertension, diabetes, and a combination of a CKD end stage. All these combinations, if you put together, a good amount of even younger patients. And Nagarjuna, we have seen a good amount of our patients were hypertensive in the younger age group, 30 to 40 and 30 to 50 age group. And many of them had a comorbidities like hypertension and diabetes. So good amount of patients may be fit into that. Many of our actually families, even clinicians, had a concern related to its use. We will talk about overuse anyway in next portion, but initially its use and its adverse effects. What was your experience? You have used in a good amount of cases. 200 is a big number to actually express. In the initial part of the trials, the numbers were not even this. So what is your experience? What were the common adverse effects? As pointed out by Dr. Abhishek, the adverse effects in almost in 5,000 patients were almost non-significant or minimal. So what was your experience?
I think I will say it is one of the safest medicines. Though the trials have pointed out to anaphylaxis, definitely it must have been documented, and every medicine has a small side effect of anaphylaxis, but we have not come across any allergic reactions as of now. And we usually give it as an IV infusion. So it is either subcutaneous or IV. If given subcutaneous, then there are local reactions sometimes can happen, is what is documented. But because we don't use the subcutaneous, I cannot comment on the side effects of the subcutaneous formulation. IV, we usually give it as a 1 hour infusion and observe the patient for 1 hour as per the standard recommendations. But till today, we have not experienced even 1% complaining of any infusion reaction because of the antibody cocktail. I think this is one thing. There was only one patient. I think this I did not even say, but one person who has used earlier antibodies for Crohn's disease and other these things. Whenever she takes an monoclonal antibody, she develops facial palsy for reasons very unclear. And similarly for antibody cocktail also, she developed a transient facial palsy. I still cannot explain how, but that was the only side effect which we had seen till date because of use of antibody cocktail. I think the concern about safety is unjustified. Just like there was a hue and cry about safety of COVID vaccines. And then finally people accepted that it has to be taken. Similarly, I think there is a lot of over concern about the safety of this antibody cocktail. We should not even think 1 second about the side effects. And if the person fulfills the criteria, you please close your eyes and give. Only thing is, there are some people now who are asking me, can I take it in the home? Even now, I'm not telling no, don't do that. Whenever we give it, it has to be in a setup where there is facility to tackle anaphylaxis, because it is a documented side effect.
Yeah, I think the hypersensitivity. Yeah, Dr. Abhishek.
See, the clearance of the antibody is also not renal or hepatic dependent.
Yes.
So it gets eliminated on its own. It's a self-eliminated. So even a CKD patients or a chronic liver disease patient can also be safely given the.
Yeah, and there is no dose adjustment safely given. It is even doesn't require any renal or hepatic metabolism to clear the drug. So hypersensitivity reactions and anaphylaxis, as like any other drugs, has been warned, but the side effect has been as minimal like any other drugs, maybe less than that other common drugs which we use routinely in our clinical practice. Yeah, you have raised a very important concern related to overuse. See, we need to know, the same thing happened with steroids across the globe, including India, including our part of the world, the overuse of steroids, and we saw the consequences of that in the second half of the second wave. So in the same way here also, as you rightly pointed out, many patients who are receiving this monoclonal antibody, not for the prophylaxis, which we actually discussed, that post-exposure prophylaxis, or in the early part of the mild to moderate disease to stop the progression, but after the patients getting the disease and got admitted and requiring oxygen in a hue and cry, the families are asking to them about the monoclonal antibody, and clinicians, without having a complete understanding about the implications and indications, some of the times they are prescribing them, which probably at this point of time is not indicated. And the only indicated doses at this point of time are 4 grams each. That means maybe around 3 vials together. That lands up to one set of the vial, which comes both, if you see casirivimab and ridimab in a point of 1.2 each. So in that form, if you take 3, they may be land up in 3.6 grams each. So that will be approximately 3.5 lakhs to 4 lakhs together. So if you are using that dose at this point of time, that's the data. Abhishek, just when you are reviewing literature, do you come across any further studies? As if you see in the initial part, the studies were comparing between 1.2 to 2.4. And did you come across any studies who are doing between the recent 8 grams versus any lower doses, 4 grams or 2.4 grams or 1.2 grams in recent times?
I have seen one study, sir. They were comparing 2 grams of each monoclonal antibody. The results are not out yet. They're comparing 2 grams to the placebo. 2 grams of each. That means total is going to make up 4 grams.
So probably we need to wait for those things to actually see the benefit of them. So now coming to the other side of the story, a few of our cases also we experienced the same thing. We given this cocktail antibodies in proper indicated patients who came to us, elderly, higher risk group with mild disease, not requiring oxygen, hospitalized, and received this monoclonal antibody cocktail. And in a very small fraction of patients, these patients progress to further severe disease. And they landed in ICU, and few of them landed in requiring oxygen, few of them landed in maybe requiring invasive ventilation. So the families and the doctors are now in a newer challenge. So we speak about that the monoclonal cocktail is to stop the progression. As we understand, none of the drugs, none of the vaccines, none of these monoclonal antibodies can give us 100% protection or inhibition, but still we escape few. So what is your take on these patients? What we say breakthrough infection after vaccination, breakthrough progression of this COVID disease after monoclonal cocktail antibodies, Dr. Nagarjun?
I think yes, if no medicine is foolproof, correct. Even in the trials, even in the trial on early COVID also, I think 1.3% of them ended up getting hospitalized. It's a very small number. It's a very small number. And what I would say is in our experience also, actually in our experience has been very positive, very positive. Definitely, some people progressed. I think I would say probably less than a 1%. They went on to develop oxygen and then they recovered. But none of our patients had actually gone to ICU or required ventilation, but definitely that can happen. It is not that it cannot happen, but that shouldn't deter us from giving antibody cocktail to the correct person. So we should always tell them that the risk, whenever we are suggesting or telling a medicine, I tell them that the chance of disease progression is reduced by 80 to 90% because of the antibody cocktail. So there is still a 10% or chance that it can progress. This is what I tell our patients also, and most of them do understand that no medicine is foolproof in COVID-19. But again, one more point I would like to say is that in those people who have actually progressed after giving antibody cocktail are those whom we had given the cocktail little later in the course of disease, like day 5, day 6, or day 7, where probably some amount of viral replication has taken place. Those whom we had given before 3 days, none of them actually progressed. 100% they became better. So I think we are still in the process of analyzing our data, whether the day of administration also has an impact. The earlier, the better. So if that is why I always tell to patients that nowadays it is better to test everything, test every fever. The earlier you test, the better it is, because the earlier you diagnose, the better you can treat.
So I think you re-emphasize that, Dr. Nagarjuna, that the earlier it is better, not even waiting for this 5 days, 7 days time. The moment you get the patient came in contact and you believe they are at high risk and they had started symptoms, the earlier it's better. See, there were some debates and questions related to its use in pregnancy. So there are some questions. Can it be given to the pregnant patients?
The current guidelines all say that it can be given to pregnant people. Pregnant people also fall under a high risk group, and it has been whatever data is there, I think is positive. Though the data is not as strong as in a non-pregnant population, but if a person if pregnant and is in the early COVID, definitely yes, antibody cocktail can be safely given.
Even recovery trial also, they have included the pregnant and breastfeeding mothers. So they were also given cocktail, the hospitalized pregnant patients.
I think the answer is a big yes.
Yeah, another interesting actually discussion happening across the many fraternities, medical fraternities, that why the cocktail is working better than the single monoclonal antibodies. See, we have seen that happening with bamlanivimab. Now we are also seeing that casrinivimab also, the cocktail is better than a single agent. Any specific points, Dr. Abhishek, from your side? You actually already tried to explain it, but re-emphasizing the point, why cocktail, not a single one?
The thing is, actually, these antibodies go and bind to the different epitopes, non-overlapping epitopes on the virus. So even if the virus gets mutated, it may get mutated at one epitope. So other epitope may still be vulnerable. So if this other monoclonal antibody is going to go and act on that epitope. So that's how even the virus gets mutated. When we combine two antibodies, monoclonal antibodies, the chance of escaping the therapy will be less.
Okay, there are questions. I think both of you can just think about these questions. Like there are some questions from the audience. They are asking, sicker hospitalized patients. Okay, we only restricted ourselves to say seronegative or seropositive. We find some difference in seronegative group, as Dr. Mathur has its own concern with that. But is there any timeline they have taken as a duration, like what we have done with mild cases, maybe 7 days, a maximum up to 10 days? Is there any timeline for a sicker group?
I think the trial which Dr. Abhishek was pointed out, I think the median time from symptom onset was 7 days. Even
7 days. 7 days.
Recovery trial. So even in sicker hospitalized patients, if at all we decide to choose, the earlier the better. I think that line will hold true any time. Okay. The earlier the better. But the only thing is that you should stick to the recommendation. You stick to the trials. You should stick to the evidence. But if you want to use it in sicker oxygen-dependent patients, you have to use the dose which is used. That is the full dose of 4 gram plus 4 gram.
As Nagarjuna sir said, The earlier is better. As soon as we diagnose the patients, we have to give them,
Yeah,
whether it is inpatient or outpatient.
Theoretically also it goes well, as he pointed out that if you are preventing the cell infiltration into your own cell or the viral cell infiltration, it has to be done at the initial. Once the cell is damaged, your own cell is damaged, preventing further invasion, once your damage is 80% or 90%, even though it stops further invasion, the damage is already been done. There are some questions related to the cross reactivity with this monoclonal antibody. Any points on that?
I think, see, what is more important is not cross reactivity between the antibodies, the cross reactivity between antibody cocktail and the vaccine. This is more important. And because it is said that antibody cocktail, monoclonal antibody cocktail, will hinder the vaccine responsiveness. So, if a person receives monoclonal antibody cocktail, the vaccination should be deferred up to 3 months. I think this is a practically relevant reactivity. But whether two different monoclonal antibody cocktails interact, I think that nobody has tried till now. And in India, we only have casirivimab, imdivimab. So there's no point in discussing about what happens when if you give some other antibody cocktail to this. But logically, there shouldn't be, because there's specific antibodies to specific epitopes.
There is some interesting question. Can this drug progress the disease? You have a patient with COVID. He was mildly symptomatic or asymptomatic,
No,
and you have given a monoclonal antibody and it will progress.
Drug does not cause disease progression. Disease might have progressed despite the drug.
So that need to be understood in that way. There are questions related to the same, like a patient who is seropositive, that is, he has taken vaccine and his antibodies titer is present and high, and he is into organ failure. Can I still attempt to use this drug?
I think he has all the reasons not to use the drug. So one, he is seropositive. Then second, he is very sick. So there is no evidence that giving the drug at this point of time will benefit.
So the other point which you already pointed out, that related to the vaccines, so we give a vaccine, we need that immunogenicity to get, and you have already given a monoclonal antibody in a milder or asymptomatic. If the patient is not already been vaccinated, so there is a duration given. Just again, can you re-emphasize that why you wanted a 3 months period to just for wait?
No, that is because the vaccines are also basically recombinant spike proteins or spike protein inserted into the vector viruses and all. And these monoclonal antibody cocktails are anti-spike antibodies. So the vaccine may not mount a good immunogenic response if given within 3 months of administration of the monoclonal antibody cocktail. That is the reason why it is recommended to defer vaccination for up to 3 months in those who have taken monoclonal antibody cocktail.
So the second part of the question, I think intermediately you answered this, but again, there were questions. If somebody has received 1 dose and now is COVID positive,
yes,
can he take antibody?
100% yes.
Yeah. Second question is, if he takes an antibody, what will be his second dose? What about his second?
So 3 months postponed. From the time of antibody cocktail, 3 months you have to defer. And I think, Dr. Venkat, there's one more recommendation which has come. Is concepts. Now we have spoken about post-exposure prophylaxis for close household contacts, correct?
Yeah.
Then what about people who are having continuous exposure?
Healthcare related, particularly healthcare related.
So they are exposed every day. So now there is a concept called a monthly antibody cocktail. How long? Nobody knows.
The half-life of 28 days has been pointed out. That
so monthly antibody cocktail 300 plus 300 mg subcutaneous is also proposed as one of the ways to prevent infection. The data, I was trying to look at what is the data behind this particular recommendation. I couldn't find, but I think I will search once again. But this monthly monoclonal antibody to prevent infection in healthcare workers also has been proposed. How cost effective this will be vis-a-vis vaccine and booster is something which we don't know, which I cannot answer. but this is another thing which has been proposed
True.
recently.
I think that's related to the recurring exposure. See, we speak about one single exposure of family members or somebody who has high risk. But when a healthcare professional repeatedly get exposed, it is very maybe not uncommon, I will say. Some of the times you get come across with a positive patient without proper protection and coming that, and they say half of the dose in every 28 days. So there is another interesting question related to what is the duration of action of a monoclonal antibody. Again, half-life or the duration, it is linked to, again, they say around 28 days is the T half, and 3 months period is probably the gap which you need to get vaccinated. I think so.
Correct.
That has been.
Perfect.
So again, there is another question is related to the permission from the department for procuring. Does it need a permission like what we have now stuck with tocilizumab and all that?
No. Luckily, no, because one good thing is Cipla has told me that they have launched adequate supplies.
Stocked adequately.
So I think the government will interfere only when there is a short supply. And as of now, I think there are enough supplies to cater to the needs of the current population. But if a third wave comes, we don't know what is going to happen, and let us hope that third wave won't come. And if at all third wave comes, then we by that time will be better off in handling the supplies.
So maybe those are the suspicions. Suppose third wave comes and you have a surge of flow of patients, and suddenly everything goes out of stock, including your steroids and low market heparin. If that situation comes, again, as you pointed out, and supply chain will be going to some control regulation. So at that time, maybe you will have to give explanation before procuring that drug. There is another question related to remdesivir. Can I use a remdesivir in a patient whom I have given a monoclonal antibody cocktail, and the patient is now started progressing the disease?
Yes, yes. This is I have been getting multiple calls from doctors about combining antibody with antiviral. See, logically they have totally two different mechanisms of action. Correct. So this prevents viral entry into the cell, and antivirals, whatever virus has escaped and entered the cell, they will prevent multiplication of that nucleic acid, RDRP blockers. So logically speaking, if we combine this antibody cocktail and antiviral, the benefit should be even more in preventing the disease progression. So there is no harm in combining antibody cocktail and antiviral. And if a person progresses despite antibody cocktail, you are justified in using antiviral.
So any experience from you, Dr. Abhishek, yes. You're being a part of intensive care. So any experience of using the higher doses or disease progression, as Dr. Nagarjuna pointed out, 1 or 2 cases of his who actually get progressed but not requiring a sicker. Do you have any experience of your case being progressed? We have seen few. What is your experience?
In our ICU, we did not give such higher doses. So we never gave 4 grams of each antibody, but some room side patients who were admitted, who were not hypoxic, they didn't land up in ICU. Whoever got the monoclonal antibody combination, they didn't progress, is what I have observed. But in our ICU, we never gave a large dose. Even if we have given low doses. So then obviously that won't be effective. So if we have to give a large dose, and then we can comment then whether it is effective or not.
So there are suspicions or doubts that what do you mean by post-exposure prophylaxis? In vaccinated people or already recovered from COVID, which we say for post-exposure prophylaxis is not a recovery from the COVID or from a post-vaccination, but they got exposed to a already diagnosed symptomatic COVID patient without adequate protection.
Correct.
If the patient is or the family who got exposed to, mainly elderly family who got exposed to a healthy, otherwise young individuals, and they have a higher risk group. So again, I probably wanted one of you to actually, maybe Dr. Abhishek can point out, what do you mean by high risk group? So we have been speaking about this high risk group for long. Can you enlist them, re-emphasize the high risk group?
Okay, high risk group patients are the patients And high risk means they are high risk to progress to the severe disease. The aged patients, age more than 65 years, BMI more than 35, patients have underlying medical conditions like CKD, heart conditions like they have a history of CAD or known diabetic hypertensive, and more importantly, immunosuppressed patients. Those are any immunosuppressive therapy in the cancer patients or any autoimmune condition patients. So these patients are a very high risk to go to the progress to the severe disease. So we need to.
What about COPD, Dr. Nagarjuna? The COPD has been included in that group.
Yes.
What is your finding in that?
All respiratory illnesses are also listed as a high risk group. So people with asthma and COPD also by definition fall under high risk. But very frankly speaking,
very few.
Unlike influenza, which targeted asthma, COPD, and ILD patients, COVID somehow targets more of diabetes, hypertension, and obesity.
True.
Similar echoing. This probably, we don't know whether the beneficial effects of inhalers or the nature of virus per se, we don't have an exact answer. But nevertheless, any respiratory comorbidity is considered a high risk.
So we had almost a similar kind of experience. No many COPDs or asthmatic patients in our intensive care unit also in the same way. Maybe it's just because we have so many patients, so many have been healthy patients also getting infected. So in that population or then that surge they lost, or I don't know, but yes, we have not seen many in the same way. So the last point probably to the discussion in restriction of time to Dr. Nagarjuna. So we have only focused till now high risk group in the early. As you already pointed out, some of the healthy patients may sometimes sink and get deterioration in your hands. So in which of these time, or what will be the timing? We know the patients category high risk group. Now I'm talking about the patients who are not in high risk group, healthy young individuals. But what will be your timing to select in a healthy individual who came to you in mild symptoms you are observing in a hospital? But what will be your timing to hit if the patient is deteriorating? And what is your experience also, clinical experience in non-high risk group?
See, as I have said, in non-high risk group will be an unlabeled indication, correct? So non-high risk group, early COVID is an unlabeled indication. But then if such a person comes in the early phase of disease, that is below 7 days, we will give them the option. So we won't say you have to take. We'll tell them there is a medicine which can prevent. And if the person says yes, can afford, we will administer the antibody cocktail. And what we have seen is even in this low risk group, definitely the rate of progression is lesser. But the question remains that they would have not progressed even without the cocktail, or they would have progressed. But it is very difficult to predict. You can't predict. So that is why what we have done is whoever is coming early in the course of disease, we'll give them an option. If they're high risk, definitely we will tell them, we will insist, and then we will make sure that they'll get the antibody cocktail. But if they're low risk, we won't insist, put pressure, but then we'll just give them the option that this is also there. If you want to opt, you can opt. Nowadays, many people are actually opting for it. Even younger people who have no risk factors, they don't want to take a risk. Educated people who already know about the antibody cocktail would want to have an extra element of protection. It is just increasing your protection 3 or 4 folds.
Are you looking just at clinically, or are you looking at anything else also in
nothing? You cannot wait for anything to happen. That is what I had said in the beginning also. The person will be fine when you give. You have to give it when the person is fine.
So another unfortunate thing which happens in many circumstances we experienced also, the many patients who can afford, who can take this drug and they have absolute indication, but they don't get this information from the primary care provider. Correct. And they land up here after 10 days when the disease progresses. And when we talk about it, or when they ask, when we say, if this need to be given much earlier before you progress to this stage, then they say we were not aware. So we feel very sorry about that. So this, I think the message which Dr. Nagarjuna and Dr. Abhishek both created to actually put across that these information need to be said to the patients who may get benefited or who will get benefited by this kind of cocktail monoclonal antibody combination in higher risk group, we who can afford and who wants willing for taking it will probably a way forward in the future. We hope the further study will clarify the doubts, whether it will be useful in a sicker group of patients, whether the dose is required or the 4 grams in both the combinations or lesser dose will be effective. I think further studies will clarify on that. With the limitation of time, I think I thank both Dr. Nagarjuna Mathur in taking out his time from the busy schedule, interacting and probably putting his clinical experience, wisdom of the literature review together. And I thank Dr. Abhishek taking out his time and reviewing the literature beautifully and putting it across to us. We thank all the audience and participants in joining us and probably interacting with us also over the chat box. Thank you all. Any final comments from Dr. Abhishek?
So, as Sir said, the take-home message would be high-risk patients, obese patients, give the cocktail as early as possible so that you can prevent the disease progression.
Thank you. Any final comments from Dr. Nagarjuna?
I'll say only one thing. Test early, diagnose early, treat early. Let the disease not progress. This is the thing which has to percolate into every village, every doctor's head, every person's head. And I think if this happens, then the load on the hospitals also will come down.
Thank you. Thank you, both of you. Thank you all. I conclude the session. Thank you.